Hello everyone, and thank you for joining us. Tonight we're going to be talking about all things knee pain and injury and really how you can make 2022 the year where you have your best year yet. Today we are joined with Dr. Keely Boyle. She is from UBMD Orthopaedics.
Yep.
You do surgery too,
yes,
right?
I do.
Yes.
I certainly do. Yep.
So go ahead and introduce yourself to everybody and kind of tell yourself a little bit about you.
Hi everybody, I'm Dr. Keely Boyle. So I am from UBMD Orthopaedics and Sports Medicine. I do hip and knee replacement, so I do first time around surgeries and also do redo surgeries if anyone ever needs a redo surgery that already had a hip or knee replacement. I did my training here in Buffalo for residency and then went away to New York City for a little while to further on my training in hip and knee replacement. And I'm back in Buffalo now and I'm in my second year of practice, about to start my third.
And how are you liking it back in Buffalo?
It's good. I like it a lot. Very different from New York City.
Yes.
The people are wonderful. My patients are wonderful. So hi to anybody if any of my patients are on, by the way. No, it's been going really well, and I love the area. So
awesome. Yeah. And now you're a converted Bills fan too?
I am completely a converted Bills fan. There is no other way I've learned in Buffalo. So yeah. There's no other option.
It's all or nothing. Yep.
There's no option. So
yeah. Awesome. So obviously, we're going to get started, kind of walk through. So let's talk about some of the most common injuries that maybe you're seeing with the knee. And actually, even before we go ahead and get started with that, can you just kind of talk through like a little bit about the knee? Because I think maybe that's where we should
start. Absolutely. So again, I do hip and knee replacement. So my focus is mainly on individuals that have arthritis of some kind, which we'll go into in a little bit. So the knee is really made up of three compartments. So there's the medial compartment, the lateral compartment, and the compartment underneath your kneecap. So this is a model that we have here, and I have to hold my mic at the same time and do this. So this is going to be really fun and interesting. So this is, I'm kind of reflecting the kneecap out of the way. This compartment right here is the medial compartment, and then we're going to turn it a little bit. And then this over here is the lateral, and then underneath this kneecap is called the patellofemoral joint. And the reason I bring up all three compartments is because patients can have arthritis in just one of those compartments, or they can have arthritis in all three of the compartments. And so you may find a doctor that talks to you if you do have arthritis about having a partial knee replacement or a full knee replacement. And that can be something we can talk about a little bit later if need be. But that's the difference between the compartments. Also, you have a whole bunch of different types of cartilage and ligaments in the knee. So that brings us to kind of answer some people's questions about types of injuries. If you can keep holding it, that would be great.
Absolutely.
So the brown that's in here that looks like a circular disc on both sides, if you can see that, I'm going to really pull this model apart.
Yeah, go
Let's
for it.
tilt it a bit. So that brown that looks like circles on both sides is a representation of the meniscus. So there's a medial meniscus and a lateral meniscus, and it's made out of cartilage. There's really two overarching types of cartilage in the knee, and we can put it down just for a second before I talk about ligaments. There's really two overarching types of cartilage in the knee. So you have your menisci, so your medial and lateral, and then you also have the cartilage that lines the ends of the bone. So you have your femur bone up top here and your tibia bone down here. Hopefully you guys can see that. I'm going to lift it up a little bit. So femur bone is here and tibia bone is here. So there's actually cartilage that lines these bones. So when we talk about arthritis, that's the cartilage that we're talking about, is the articular cartilage. And this model doesn't have a different color on it, but really it's actually attached to the bone and lines it on both sides. So you can injure the meniscus, either in a sporting injury from when you were younger, or it doesn't have to be when you were younger. You can injure the meniscus, it can tear, it can fray, and then you can also injure the articular cartilage. And then you can also injure your ligaments. So there's 4 ligaments in the knee. There's your ACL, your PCL, your MCL, and your LCL. Your ACL goes through the middle of the knee. Your PCL is in the back of the knee. Your MCL is on the inside of the knee. And then your LCL is on the outside of the knee. So they all work to keep the knee where it's supposed to be and help your knee go through an entire range of motion in a stable fashion. So people can tear any one of these. The most common ligament torn is the ACL, which we hear a lot about. And that can be torn in so many different fashions, whether it's a sporting injury or some other type of accident. And once that ligament goes, there's different options for people. If you don't have any arthritis in the knee and you tear your ACL, usually the option is don't fix it or fix it with one of my colleagues who's a sports medicine surgeon, orthopedic sports medicine surgeon, and they actually do ACL reconstruction. Now, if there's a lot of arthritis in the knee and you also tear your ACL, you're looking at something more like a joint replacement. So you're not going to reconstruct someone's ACL if they have a lot of arthritis already, because you're just going to still be in pain even though you have a nice new ligament. So, and then we talked a little bit about the meniscus, but the meniscus can tear multiple different ways. If you're younger and you have an isolated meniscus tear, my sports medicine colleagues can repair that. But most commonly, the patients I see have some underlying arthritis, and their meniscus has been torn for a long time, and it's kind of frayed, which we call degenerative. So that's a little bit different than an isolated tear, where someone kind of falls or twists their knee and they tear the meniscus. Again, different options for kind of what the knee looks like, depending on arthritis or no arthritis involved as well.
Wow. So much knowledge and information
Lot.
there.
That was a lot.
Thank you. Yeah, that was great though. It really helps understand, obviously, what the knee is. So kind of talk about then, you see somebody coming in and they say my knee is in pain. So how do you really go about working to understand their diagnosis? And maybe somebody that's watching is saying, I have knee pain.
Right.
What qualifies as something that, they need to show up in your office?
Yeah. So happy to see anybody, first of all, if you have knee pain. Doesn't matter who. I can certainly, myself or any of my colleagues at UBMD Orthopaedics can get you in to see somebody that's the right knee person, since there's a lot of different knee people. So the first thing I do is, honestly, I get an x-ray. So if you were to come see me, that you're going to go get an x-ray in our wonderful x-ray department, and then you'll come see me. So I look at that x-ray, and the x-ray shows me bone. So it's not going to show me your cartilage or your ligaments. You need an MRI for that. And that's, a lot of patients ask me, do I need an MRI? So I look at the x-ray first and I evaluate, basically I'm looking for arthritis, okay? And there's a lot of things on x-ray that I can see regarding arthritis and how much arthritis, where's the arthritis, where's the person's pain, and then I do a physical exam. And that physical exam evaluates ligaments, cartilage, range of motion, all sorts of things. Between the x-ray and the physical exam, I narrow down my diagnosis, whether I think it's purely arthritic, ACL, meniscus, other ligaments, things like that. And then if I don't see anything on the x-ray and the physical exam is telling me something else, I will usually order an MRI. The MRI is going to show me the cartilage and the ligaments and the bone and all sorts of things. And then the person will come back to my office after the MRI and we'll kind of talk about it and correlate it with the physical exam.
And now you talked about arthritis a little bit. So can you just elaborate more on what specifically is arthritis, and are there different types of arthritis?
Yes. So let's start with the types. So there's osteoarthritis, which is the most common. So that's when people think of a slow degeneration of their joint. When their doctor says, oh, you have arthritis, they're usually talking about osteoarthritis. That can happen for a lot of different reasons. It's genetic, it's biologic, it's environmental, it's activity related. So it's different for everybody. There's post-traumatic, which means that you had an injury at some point, and that started the arthritic process. So it could be an ACL tear when you were younger. And that led to the knee being a little bit unstable because the ACL wasn't there anymore. And it led to a meniscus tear because the knee wasn't functioning properly. And then that meniscus tear then led to the other cartilage to tear, which led to arthritis. Then there's inflammatory arthritis. So that's, a lot of my patients have rheumatoid or lupus or other types of an inflammatory kind of autoimmune disorder. That can lead to arthritis and usually affects the entire joint, not one part of the joint. So that person, for instance, would not be a candidate for a partial knee replacement.
It has to be the full.
The full.
Okay.
Yep. So those are the big categories of arthritis.
Awesome. And then what are they, like when people have arthritis, what is something like signs and symptoms that they're kind of maybe struggling with this?
Yes. So there's a huge spectrum for arthritis, especially in the knee. The hip's a little bit different, but the knee is a very wide range of symptoms for arthritis. So some people starting off have a little bit of arthritis on the inside of their knee, which is the most common, and they complain of isolated pain on the inside of the knee. And it can be pain during the day, pain with walking, pain with biking, pain with really any activity that you would like to, pain while you're working, nighttime pain, like a dull ache, and it's just you can't get comfortable. And so that's all common for arthritis. Some people can have sharp pain. They describe it like someone's putting like a knife in their knee. But that nighttime dull ache, that's really common for people. So sleeping can be a problem with arthritis. And then you have people all the way up to they have horrible, no cartilage left basically. They're bone on bone everywhere, and their pain can be a little bit different. And those people can have a lot of symptoms of instability, which means that the knee gives out on them and you can fall. So that's when I start to really get worried in my patient population, is if they get to that level and the knee is so kind of quote unquote far gone. I don't like using that term, but when the knee's really bad, it becomes super unstable and people can fall. And bracing at that point sometimes isn't even an option.
Yeah, and then obviously potentially injuring things that...
Correct, that weren't injured before. Yep.
Which is nobody wants when you're listening to. Awesome. So I think now it would be great, you kind of talked about it a little bit, but let's go into more detail about some of those common injuries too. So you talked about the meniscus and the meniscus tears. So can you elaborate? I think you touched on it a little bit, but the difference between a traumatic and then that degenerative meniscus tear too?
Yep. So the traumatic is the one where most people that have a traumatic meniscus tear don't have a lot of underlying arthritis. So remember, arthritis is we call it the loss of articular cartilage. That's the cartilage that lines the ends of the bone. Okay. It's stuck to the end of the bone. When people start to lose that, that's what arthritis is. The meniscus is a little bit different. The meniscus is involved in arthritis, but you could have a little bit of arthritis and not really have a bad meniscus tear or anything, and then tear the meniscus. Right, so that would be like a traumatic tear in the setting of arthritis, and then that's the middle spectrum of people, and then there's people on both ends of the other side. So the true traumatic injury is someone that really doesn't have a lot of arthritis or damage to the knee yet. Okay. And then you twist your knee, you fall, skiing or some type of accident, and you get a meniscus tear where it tears in one part of this brown area. Okay. That can be handled in a couple different fashions. For the most part, we try to wait it out, and we'll talk about what we do for non-operative things. Some of my sports medicine colleagues will go in and they can trim out the meniscus. If patients are a lot younger and they still have a good blood supply to the meniscus, oftentimes my sports medicine colleagues will try to repair the meniscus. Okay. But I'm going to defer to my sports medicine colleagues to make that decision. I get a lot of patients that ask me, can it be repaired? Can it not be repaired? Usually by the time you see me, we're talking about knee replacement. So we're not talking about going in with a scope and cleaning things out. So that's the option when you have a tear of the meniscus without a lot of arthritis. Now you get into the degenerative end, right? So the degenerative end means that your knee has gone through multiple tearing of the meniscus in multiple different places. That cannot be handled with a repair. So that's a lot of kind of wear and tear on the inside or outside of the knee, and the meniscus really isn't viable anymore. So a lot of my colleagues will go in and they can trim it out with a scope to try to make people feel better for a while, but oftentimes you may be looking at some type of replacement type procedure in the future.
Right. Yeah. Which is, you'd rather deal with it sometimes too. Yeah. So any other common types of injuries that we really haven't discussed?
In the sporting world, yes. So again, a lot of people that are really involved in kind of high level sports or even recreational sports, you can get an MCL tear, which is your medial collateral ligament, or even an LCL tear or a PCL tear that sometimes happens in car accidents. So any of those ligaments can tear. It's a little bit less common than the ACL and the meniscus that we're talking about. Even people can get a quad tendon or patellar tendon tear. That's your quad tendon and your patellar tendon attached to the patella, which is the kneecap. Yep. And that whole system, quad tendon, kneecap, patellar tendon, that allows you to straighten your leg. That's what allows you to extend the knee and extend the leg. So if any one of those things tears, you can't extend the knee fully. So for example, I had a patient that fell on the ice over the winter, and he fell directly onto both of his knees, and he had a patellar tendon rupture. So he pulled his patellar tendon right off of his kneecap. So we went in and we repaired that. Yes. So again, those injuries are a little bit less common, but they do happen. And we evaluate them with physical exam and usually an MRI, and then we talk about fixing it.
Awesome. So let's kind of dive into some of those non-operative treatment options that you kind of discussed too. So I think one of those that people most commonly associate is maybe a cortisone injection.
Yep. So usually if you're talking about injections, you have gotten to a level in your knee where you have evidence of arthritis.
Okay.
So either on x-ray or an MRI. So somebody along the line or a physician has said, you have arthritis in the knee, and they're talking to you about all different types of non-operative interventions, one of which is injections. The first round of injections in general for most orthopedic surgeons and joint replacement surgeons is a cortisone injection. So cortisone is a steroid. It's an anti-inflammatory. Think of it as an anti-inflammatory, and it usually doesn't have a lot of risks associated with it. I do have a certain percentage of patients that have an adverse reaction to cortisone, and the knee gets more annoyed for the first couple days, and then it'll settle down. So, but that's only about 1% to 2% of people, but it does happen. I've had it happen to a couple people over the past 2 years or so. But in general, the cortisone, because it's an anti-inflammatory, and it really calms the inflammation down in the knee, which can help with pain for weeks to months.
Yep.
The more cortisone injections people receive, the less effective they are usually. So some of my patients get 6 months more. Some people get 6 weeks. It kind of all depends. And then there are some studies looking at multiple cortisone injections not being very healthy for cartilage. So if someone comes to me and they do have pretty healthy cartilage, I'm an advocate for not receiving a cortisone injection unless there really is a reason for me to give it to them. But if someone comes to me and they have really bad arthritis and really the cartilage is not healthy anymore and they're not ready for surgery for whatever reason, then cortisone's a good option. And then I think there's some other injections I did want to mention too.
Yeah.
So there's gel injections. Gel injections are basically like injecting a lubricant into the knee. There's a couple different kinds, and there's some science behind it, and then there's some not science behind it. So just talk to your surgeon about the gel. I'm going to reserve my opinion for this particular session on gel, but certainly it is an option to discuss with your surgeon. And then there's PRP. So PRP is becoming more widely known. I have lots of patients that ask for it. It's platelet-rich plasma, which is your own blood that gets spun down into a concentrate and injected back into the knee. Right? It's pretty safe. There's some really good literature on it. I personally don't do this injection. My sports medicine colleagues do it for me. They're very well trained on how to do this. They have the tools to do it. And I have some patients that have had very good success with the PRP. And then there's a whole nother world of injections called stem cells. That still has a lot of literature that needs to be done on it. A lot of studies that need to be done on it. So I would just be a little cautious if you're interested in stem cells. I don't think, in my personal opinion, we're quite there yet to offer that widely to patients. I think we will get there in the future, but we're not quite there yet. Okay. So that's my talk on injections.
What about, do you find that any like vitamins or medications?
Yes, I love the fact that you asked that question. So my mother is an arthritis nutritionist.
Wow.
And she's a fabulous lady. And she has helped me design an entire nutrition protocol for my preoperative patients or patients that are not interested in undergoing surgery. So there's a vitamin regimen, a supplement regimen, and a dietary regimen as well that focuses on inflammation. The whole focus is on reducing your body's inflammation. So I'm going to start with a couple ploys I would like to put out there. Yeah. One of which is smoking. So smoking cigarettes is really inflammatory to the body and really causes joint pain. It can cause joint pain because of the inflammation that the byproducts of the cigarette put into your body. So that's something that we can modify and help patients with to get some of the pain down. And then other things like sugar, like processed sugar, which I eat. I mean, we all eat, but limiting those things like sodas and candy and processed deli meats and all that stuff really increases the inflammation in your body. So even doing these little things and changing those things can actually change your pain in your knee. So wow. It's a little bit, yeah. And then on top of some of the dietary things is the vitamins and supplements. For example, turmeric and glucosamine chondroitin are two pretty well-studied supplements that offer an anti-inflammatory response in the body. And look, I mean, you're not going to wake up the next day and have no pain. That's not how these work. This is a really dedicated approach to changing the way you live, and incorporating turmeric and glucosamine, chondroitin, and all these things that can kind of help with the inflammation.
And obviously turmeric is it's a
spice. Yeah, it's an Indian spice actually, and a lot of us in the U.S. don't cook with it very much.
Yes.
So it comes in a pill form, and there's a couple companies that are very nice companies that offer a very raw form of turmeric or other things. So finding those, doing a little research on supplements is always good.
Yeah.
For which companies are best for the supplements.
And then for glucosamine and chondroitin, are those things you can find naturally in food, or no, they should be taking supplement versions of them?
In general, supplements.
Okay.
Yep.
Okay. Anything else, non-operative treatment options that you feel like we haven't touched on?
Yeah, so there's keeping your weight in check is really good. That helps decrease the forces through the joint. Certainly if we're all carrying more weight around, it's a lot more force through our knees, especially going up and down stairs. And then, so weight was one of the things I wanted to talk about. Another thing is, which we all probably know, but things like icing. So alternating between ice and heat and elevating the leg at the end of the day is really important. And then there's things like compression sleeves. They're not a knee brace. So if you have a specific injury and your surgeon's telling you need a knee brace, that's a little bit different than what I'm referring to with people that have an arthritic knee, which need a little bit of compression on the knee to help with the swelling.
Yeah.
So that's a compression knee sleeve. And those you can get on Amazon or Walmart or Walgreens. And then staying very mobile. So keeping the joints lubricated and mobile is really important, which is what you guys really, really help with, both before and after surgery.
Yep.
So biking, walking, low impact activity, elliptical, those types of things that are low impact. Swimming.
Yeah.
I love swimming. I love water aerobics. I had a wonderful patient ask me the other day all about this water aerobic routine that she does, and we've been able to hold off her knee replacement for 2 years because of this water. Yes. So I'm a huge fan of those low impact activities.
Awesome. So we have a couple questions, but before we jump in, can you just tell everybody that's watching the best way to schedule with you?
Oh, yeah. So again, I'm Dr. Boyle. My first name's Keely. I'm with UBMD Orthopaedics and Sports Medicine. The number to our main offices, which is probably the easiest way, or to get in touch with myself or any of my colleagues, is 716-204-3200. So 716-204-3200. We have a great team of people in our call center, and just ask for myself, Dr. Boyle, or any one of our doctors. You can get through that call center.
Awesome. So the first question we had was, had medial meniscus surgery 20 years ago. I get pain in that fully bending knee position for child's pose, basically.
Got it.
And then never riding his bike though. Any special exercises he can do?
Yeah, so when you're in child's pose, you are loading the medial compartment of the knee. So you're compressing that compartment, which is probably why you're experiencing pain in that where your medial meniscus is/was, kind of depending on what your type of surgery was. So biking is a great activity, and elliptical and walking are really good activities as well, and swimming, which we talked about.
Yeah.
But any type of thing where you're doing high bending exercises, or any type of those, basically those yoga moves, they can put a lot of pressure on the inside of the knee. I'm not saying stop doing it. You should definitely keep doing it if you love to do it, but you might find that you may be in more discomfort in certain poses, and you have to avoid those poses.
Yeah, and I think for that too, if this certain individual loves doing yoga, just maybe letting the yoga instructor know that that's bothering you, and they can help find modifications so you're not in that position.
Nope, absolutely.
Awesome. So this individual had a total knee replacement 10 years ago, but still has pain, exercises regularly. Any thoughts? Two big questions that I ask patients. I see a lot of people that have had knee or hip replacements done years ago from all different walks of life and area of the country and things like that. The biggest question is, have you always had pain in the knee since the surgery, or did you do well for a while and now you're in pain? Okay.
So there are two different facets of people there, kind of patient populations for after knee replacement. And I I personally would want to see that patient in my office and get an x-ray and examine them, because there are so many things that can go wrong with bionic parts, right? Like we're actually putting metal and plastic into people. There's a lot of things. We're all human as surgeons. Things can happen, things can go wrong, things can break, all that stuff. So it's hard for me to make a recommendation of what to do if you've already had a knee replacement and you're still uncomfortable, because I don't know what's in there or what might be wrong. And it very well may be just changing some of your activity level, but it very well may be we need to check out the knee a little bit more and kind of go from there.
Great. And then what causes a lump behind the knee that makes it difficult to straighten the leg?
Yeah, so that's most likely something called a Baker cyst. So a Baker cyst is think of it as a fluid-filled pocket. It is when you have a meniscus tear in the knee. We talked a lot about meniscus tears. If you get a meniscus tear, the fluid that's inside the knee can leak out into the back of the knee, and that meniscus tear acts as a one-way valve. And the fluid cannot get back into the knee. So it creates this pocket of fluid in the back of the knee called a Baker cyst. There's not a lot to be done about that except get the meniscus addressed or the inside of the knee looked at. So I would really advocate, don't let anyone stick a needle in the back of the knee and try to drain the Baker cyst. Because it'll just keep coming back. And you really don't want needles introduced into the knee multiple times. So
I don't think anybody wants that if we're watching at home.
No. So that's my only, because there are some people that do try to drain those things and then they keep coming back. And patients say, well, why is it coming back? So it's really a one-way valve, sometimes through a meniscus tear or a degenerative meniscus tear.
And then they're not really fixing the root problem of what's going on too.
Exactly. Yep.
Awesome. Well, great. This was super helpful.
Fantastic.
And, one more.
Okay.
Still have numbness in knee from 2014 replacement. Does it ever go away?
So it depends on where the numbness is. If the numbness is on the outside of the knee, which we call the lateral side of the knee, no. There is a skin nerve that anytime you have a knee replacement, we all go through that skin nerve. And most patients after a knee replacement have numbness on the outside of the knee. There's a big pocket of numbness, which can be a little disconcerting with certain clothing wear, or honestly, shaving your legs is really uncomfortable, to be honest, because that area is really numb. So unfortunately, no, if it's on the outside of the knee, it will probably not come back.
Okay. What about if it was anywhere else?
If it was anywhere else, it might be related to something else, maybe not the knee. So I would, again, want to see where that person was having some numbness to evaluate them fully before I jump to saying what it would be.
Yes. Awesome. Well, thank you for answering that one last one. It snuck right in. So we're going to be sure to send over Dr. Boyle's information as well. Thank you so much.
Yeah, absolutely.
And then we're going to be right back, and we'll have physical therapist Garnet Loveday here to kind of talk about what exercises you guys can be doing at home to hopefully combat some of that pain. So if you have to come in, maybe we'll help before, and hopefully if not, we can prevent them from having to come in.
That would be great. All
right. Thanks, guys. We'll be right back.
Thanks.
This is where Leah learned to dribble, where James first picked up a brush, where Bella made meal kits for neighbors in need. This school year, many YMCAs are transforming some of their spaces for virtual learning, dedicating staff and even providing meals. So now, this is also where they will master long division, study photosynthesis, and learn when they need support, the Y is there for them. The Y, forever learning for a better us.
Pain was really bad, and it was very crippling. A lot of pain. Yeah, there were times when you thought, this is it. The main thing that it really prevented me doing was from being with the grandchildren. But the exercises that he taught me, little by little, I saw progress. I'm back to my normal life. Besides getting you better, they teach you how to live a life that will prevent you from going backwards again. They all care about the patients. That's where you're going to find your hope, and that's where you're going to feel better. I'm back.
All right, and we are back. I am extremely excited to introduce our next guest. I want to introduce you all to physical therapist Garnet Loveday. Hi, Garnet. How are you?
I'm doing well. How are you?
Good. You want to
Good.
go ahead and introduce yourself to everybody watching from home and kind of give them a little bit about you?
Sure. My name is Garnet Loveday. I graduated from UB in 2015. I opened the Kenmore Clinic that's off Delaware Ave in 2017, and then we just opened our Hurdle Ave Clinic about 3.5 weeks ago. And we're really excited. That's a high performance clinic, so we have a lot of capacity to treat athletes, but we treat the general population there as well.
Very exciting. So I think what we wanted to do is just dive right into it and talk in general terms. So talk to me about some of the big misconceptions that you find when working with patients for knee pain.
Yeah. I think one of the biggest misconceptions is that we need to train the knee joint itself. I think of the leg as a chain of 3 links. So we have the hip joint, the knee joint, and the ankle joint. And all 3 links in that chain have to do their job. And when they're not doing that job, typically another link is overloaded. So when we're talking about knee pain, I'm usually evaluating the hip and the ankle to make sure that the neighbors are doing their job correctly such that they're not overloading the knee joint.
And talk to me about, maybe somebody that has arthritis, they just heard from Dr. Boyle and saying, oh, that kind of sounds like me, or maybe they feel like they have a meniscus tear. Does that mean they automatically need surgery in your perspective?
No, not at all. I think first we need to evaluate the quantity of dysfunction. And if it's a soft tissue dysfunction, we can typically change that with PT. Additionally, there's some pretty cool research suggesting that even meniscus tears have similar outcomes with meniscus debridement a year out compared to non-surgical / PT care. So we know that there's a lot of meniscus injuries that don't really need surgery. They just need PT care, and they'll have the same outcomes as a surgery 12 months out.
Awesome. That's great to hear.
Yeah, it is.
So talk to me about how people can utilize exercise to help keep their knees in good health too.
Sure. So I think of things in terms of mobility and stability. So they have an inverse relationship, and most of the patients that I evaluate are hypermobile and they're
What
not
does that
stable.
mean?
Yeah, it means their joints move too much.
Okay.
So they have lots of motion at their knee joint, but they don't have enough stability in the neighboring joints. So as a result, the knee ends up taking too much force because it's got bad neighbors.
Okay. And there's sometimes this idea that if they're doing, if they're exercising, they could wear their knee out faster. Is that really true?
Yeah. So only if you're doing the wrong exercises.
Yeah.
If you choose the right tools, you're typically good to go. So designing a program that's appropriate for the individual in question is the most important part.
Great.
There. So yeah, and exercise is not a bad thing for our joints. It's absolutely necessary. It's just about doing the right exercises.
Awesome. And then I think you highlighted a little bit when you were talking about the full leg, but if somebody has maybe knee pain or knee instability?
Yeah, sure. Instability or arthritis or number of
Anything
conditions.
like that, where should they be focusing to kind of help that area too?
Yeah, I primarily focus around the hip. Most knee patients that I evaluate have a lot of weakness around the hip that's causing the knee joint to take too much stress because the joint above isn't doing its job. And then typically tightness around the calf. So or tightness around the ankle. So if the calf is too tight, it won't allow the knee to do what it should do.
Awesome. Any exercises you recommend people avoid?
Yeah, not to knock conventional exercises in a gym, but there's a lot of conventional machines that are not great places to start when it comes to knee pain. So we operate in 3 planes. There's side to side, forward, backward, and there's rotational motion. So we need to stabilize all 3 planes of motion, and machines like knee extensions or leg press, hamstring curls, they all operate in 1 plane. That's just forward, backward. So it doesn't really tackle the whole equation. We need to operate in all 3 planes, and we're typically strong in that 1 plane, so we need to add exercises in the others.
Great. Well, I think we're going to kind of walk through what you would recommend instead of those, right?
Sure, yeah.
Awesome. So let's go ahead and talk through the first one that you would want to see people doing to combat knee pain.
Yeah. It really depends on the knee injury itself, but I like squats. Squats are a great way to learn how to move in that forward-backward dimension.
Great.
I really like monster walks and bridges. Those are good ones too. I typically like stretching around the calf, so calf stretches are also beneficial.
Great.
Yeah.
So we talked about squats there. So maybe for somebody at home, you want to show me how to demonstrate
Sure.
a squat? too,
Yeah.
or you can demonstrate it yourself.
I'd
Whatever you
love
think.
to be the demo.
You want to do it?
Sure.
All
Or
right.
if you'd like, we could use you as the patient.
I'll be the patient. You
Okay.
show me what to do, okay?
Deal. Okay. So I usually show squats by a wall, so we have a governor. We know how far the patient is moving every time they squat.
Great.
I like it better than a chair squat because the chairs are usually too low.
Okay.
But I would start you next to the wall, and you'd be, well, you know what, just for everybody on camera, maybe I'll have you face off to me.
Okay.
So when you're getting into a squat, you want to hinge through your hip primarily, so getting your butt backwards as you reach forward. That would be a proper way to squat, driving forward and backwards, trying to get your hips moving primarily, rather than having lots of forward knee drive. When the knees go forward, it puts a lot of stress on the knee.
Okay, so hips, like
Feet shoulder
feet
width
shoulder
apart.
width. Okay.
Yep.
Hips, shoulder width. Yeah, that's what I was going with. It's
been a long day.
guys. Jinx. All right, so yeah, feet, shoulder width apart.
Yep.
Where is the pressure of my feet going?
You want to keep pressure on your heels.
Okay.
And then you're gently bending through both the hip and the knee at the same time, but primarily through the hip as you're getting your chest forward.
Okay.
It reduces the necessity for the knees to drive forward.
Mm-hmm.
That's typically a position that causes pain.
So almost feeling like I'm reaching back
Yep.
versus doing a forward thing.
Yeah, reaching
Okay.
back with your bottom.
Great.
Yep, exactly.
Awesome. And if people are like, okay, I can definitely add those in, how many should people be doing? How frequently should they be doing them?
I usually start with pretty vanilla 2 sets of 10 just
Okay.
to test it. And then if patients do well with that, we can increase the depth or increase the amplitude of the movement. And we can also add weight to it. But I start with 2 sets of 10, and if that's well tolerated, we can move to 3 sets of 10. And then I typically start adding load to it in the form of dumbbells, or we increase the depth of the movement.
And how many times a week should they maybe be doing those?
Strength work, I almost always keep to 4 days a week.
Okay.
At least to start, 3 to 4 days a week is good. Stretching can be done every day. In fact, stretches can be done multiple times a day, but strength stuff I'm typically keeping to just a few days a week.
Great. And then the other one you talked about was the calf stretch, opening up those calves, because obviously we talked about hips and then we talked about calves to work around those knees. So you
Yeah.
want to kind of show me what that would look like too?
Sure, yeah. So I usually use hands on the wall, like a traditional runner stretch, with 1 foot back behind you, and both feet are straight. That's really important. And you're choosing a distance that's comfortable. Your front knee is the driver, so as you bend your front knee,
I'll come
Your-
this way too. So
Yep.
you can see.
yeah, so if there's a wall here, exactly, and your back foot is straight, that's really important. Most people have their back foot turned out when they do this, or they need to check their back foot a couple times throughout the set of 10 to 15.
And how long am I holding it when I glide forward, did you say?
I'm not a big fan of holds. You
Okay.
can. There's nothing wrong with it, but if we're looking to
Just keep on moving?
yeah,
Great.
just keep moving back and forth through it.
And you said how many?
I usually do 10 to 15.
Awesome. And
Yeah.
then obviously do the other side too. So
If
we
you
don't-
can, yeah. Unless this is your sore knee, and if your sore knee is put in front and you're bending through your sore knee, that might not feel great. So sometimes I keep the sore knee as
Good to know.
the calf stretch.
But then as they hopefully improve the knee, then we could add both in.
Then we
too.
try to make them equal,
Awesome.
indeed.
What else you got for me?
In terms of exercises?
Yeah.
Yeah. So I like bridges. I don't know if I'd want to have you lay down on the floor. You're dressed so nicely.
So maybe give me some,
I like lunges too.
Yeah, great.
Lunges are another good one. There's various ways to do a lunge, but I like teaching a rear knee straight lunge.
Okay.
So you step forward with one leg, but your back leg stays straight. And it's a little bend in the front knee, but primarily a hinge at the hip. So you're
Okay.
bending forward at the hip. Yep. So that way we're loading up the glutes, the buttock muscles. We're getting a little load through the hamstrings, but we're not putting a ton of load on the knee itself.
Yeah, I feel it in the glutes too.
Great.
Yep. Great.
Been sitting all day.
I have been sitting all day. I told Garnet before that I was in meetings all day, so it's good. I'm getting my exercise in now too.
Yes.
And how many of these?
For lunges, I keep the same 2 sets of 10 to start, as long as it's well tolerated, and then we can increase to 3 if people do well with that.
Great. And then you kind of talked about moving in different planes too. So
Yeah.
with lunges, could they kind of do some variation in there?
Absolutely, yeah. So we can work through multi-planar lunges. So we can lunge to the side, so we can get into a side lunge, where again we're hinging at the hip, bending a little through the knee. We can work into the forward lunge that Julia just showed. We can also work into the rotational plane with a rotation lunge like this. So there's a number of ways to get into lunges, but I like working each plane so that we gain stability in all 3 planes.
Awesome. So really hitting all 3 that we're looking for at one time.
Yeah, exactly.
Any other ones that you could think of?
There's a lot of them, Julia. Oh my goodness. We could do step ups too.
Yeah.
So if we show with a step here, this is a little bit of a rickety stool, so please don't fall off this. But I like to teach it when you step with your front foot onto it, you make sure your heel's on and you try to push through your heel as you step up and then return. And you can see Julia reaching for the wall there because she might be a little unstable in that side-to-side plane. It's probably the stool, actually.
It's wobbling on me, guys.
Okay, we'll give you credit for that,
Yeah.
Julia.
But if they do have some instability, then there's always good to have a wall here too.
Good to have a little hand support when you first practice the exercise, indeed.
Yeah, so if you don't have a step like this at home too, they probably could use some stairs.
Yeah,
maybe too.
you could do this on
Just be
the
careful.
first stair.
Yeah, on the first, right?
Yeah, the first stair,
Not
yeah.
the top.
Yeah, don't practice step downs on that top stair.
Awesome. And then would they alternate or?
It depends on the tolerance in their affected knee. So I may have them work a short step. It might be 2 or 4 inches at first, and then we can increase the height as they tolerate that, because there's obviously going to be more knee bend or more knee excursion with a taller step. So you could alternate side to side as long as you tolerate that.
Great. And then a lot of these, I mean, none of them are machines. So can you explain why these are maybe better than some of those that you talked about too?
Sure. Yeah. Machines work around rigid joints, and those joints are typically built around the anthropometrics of a 5'10" male. So unless you're a 5'10" male, most machines aren't going to be designed optimally for you. And those rigid joints also restrict motion in other planes. So as we talked about before, we want motion in 3 planes that's easily controlled by the hip, the knee, and the ankle. So if we're using a machine, it's guiding our motion, and it's not really building patterns within our mind that we need to achieve normal mobility in our 3-dimensional environment.
Awesome. Well, this is all great, and we're going to send an outline to everybody who signed up, kind of walking through how to really optimize the knee and prevent any pain, and if you have pain, how to really work through that. Garnet, any last, take-home messages about what people need to know for having knee pain and exercise?
Yeah, sure. Knee pain is not a death sentence, and there's a lot of things that you can do conservatively before you're considering something like a surgery. So things like, and I know this is a tender topic for some, but things like losing weight, making sure that you're getting enough sleep, making sure you're drinking enough water every day, like you're treating your body holistically well, and then you're also doing things day to day that don't cause knee pain. If kneeling on your knee causes knee pain when you're gardening this spring, to all you gardeners, kneel on your other knee or get a kneeling pad. Those are good things to do. So don't do the things that hurt it. And if things that hurt it are the things that you love to do, try to modify them so you're not beating up your knee. And then make sure you're practicing some mobility and some strength exercises, because we need to be able to move with the mobility exercises, and we also need to have strength, because what we do day to day, whether you're dragging flower pots around the garden or you're throwing grandkids over your shoulder, they all require strength.
Awesome. We do have one question. So they
Sure.
said, I can't bend very well. What can I do to get more bending with the knee and ankle? They had a replacement in 2014.
Okay. Yeah. So it depends on what kind of replacement, if it's a partial or a total. And it depends on if the knee is scarred down after the replacement too. Sometimes we see scar tissue that grows after knee replacements, and that really inhibits motion. So sometimes we need to get in there and do a lot of soft tissue work. We can use rollers or Theraguns. There's a lot of things that we can do. At home, yeah, we can work into some stretch, but we don't want it to be a painful stretch. It may be that if you can't bend your knee first, we need to practice straightening your knee first. And once we've got your knee straight, then we can start working into bending exercises. But we want to kind of dollar cost average into bending exercises. You don't want to try to get 90 degrees of knee bend when you only have 20 degrees from the get-go.
Great. Another question we had is, when you injure your knee, what type of things do you recommend trying to start out with if strength exercises like squats and lunges are too painful?
Yeah, that's a great question. I get that all the time. I was a personal trainer before I was a PT, and I got questions like this in the gym too. So we want to work around the hips and around the ankles. We also work on core muscles, because your core muscles do impact your knee performance. But I like to give a lot of hip-based exercises first. Let's get the hips stable. I don't know if the camera can see me here, but if I am to show, the ankle joint can move up and down and side to side. There's 2 planes of motion available there. The knee joint is a simple hinge joint, just bends and straightens. So the knee can't really control side to side or rotational motion, but the hip is unique because it can go forward and backwards, side to side, and it can turn out and turn in. So the hip needs to be able to control those 3 planes. So I try to give exercises to patients like maybe bridges, so you're not bending under load, you're laying down, or slider exercises where you're sliding with your affected knee and you're working on your opposite hip joint. So we're doing exercises to strengthen the hips first. So maybe clamshells and bridges and some edge of the table planks, things like that I would start with in that question.
Awesome. Thank you.
Yeah.
Well, for anybody who's looking to get a more personal or individualized approach, what should they do?
Yeah, so I mean, I'm biased, but I would say let's get you into a PT. If you're not sure what to do and you're just you're talking with your trainer in the gym and they say, well, we're just going to hammer knee bending, and you say, well, knee bending really hurts. It might be you need to take a step up and see an orthopedic specialist like a PT, and we can help design a program that you can maybe safely complete in a gym or you could do from your home.
Awesome. Well, thank you again, and thank all of you for watching at home. We hope you really enjoyed it and found it helpful, and we appreciate all that you guys did and came in and helped out. So have a wonderful evening and enjoy the warm weather that's coming up, right?
Yes, yeah, I believe it was 63 today, so
I
it's
know,
almost
it was
already
great.
here.
Scorcher out there. So